Next speaker, Professor David Cranston. His topics will be ultrasound-guided HIFU application in Oxford. Professor David Cranston is the president of International Society of Minimally Invasive and Virtual Surgery, and also chairman of exclusive committee of the Oxford Center for Mission Studies, and clinical director of high-intensity focused ultrasound unit in Oxford. So now he's going to give us lecture. His title is Ultrasound Guided HIFU Application in Oxford.
Well, it is a great pleasure to be able to share with you today our experience of high-intensity focused ultrasound in Oxford over the last 20 years. And it is always much better to come in person, but with our current problems with COVID, of course, that is not possible, or hopefully I will be able to see many of you in the near future. Many of you may have been to Oxford, but if not, you would be very welcome to come at any time, and I would enjoy showing you around. So here are the machines that we have. This is the first building that we had in the West for HIFU machine. We had the JC200. Now we have a new radiology cancer building, and we have a room in here where we have the JC200. And HIFU is wonderful. It follows the demands of William Hosler, who said diseases that harm require treatments that harm less. And also the ancient medics who said, first do no harm. We all know, I think, how ultrasound works. Normally we just look at the image, but of course with HIFU, if you put the power up 10,000 times, then you can destroy tissue. We have in Oxford a big preclinical division with Professor Konstantin Kusios. He is, you can search for him on the website, working in this building, and he has many very high-powered preclinical uses of HIFU. But clinically, we have treated a number of different organs, which I will talk about today. And we are currently looking at pancreas, hoping to look at breast, hoping to look at metastatic renal cancer, and further studies on primary renal cancer. And here are some of the experimental ones that Konstantin is involved with, and I will talk a little bit more about some of those. So we had the first machine from Chongqing in about 2002 and worked on liver and kidney, looking at the safety and toxicity of the treatment. And we had about 56 patients with livers and kidneys. Some had HIFU treatment and we looked at them radiologically. 7 had HIFU treatment and then they were resected and looked at histologically. Likewise with kidney, 7 surgical, 14 non-surgical. So we did have the histology on quite a few patients. Very few side effects, occasionally blisters on the skin. And this is the team that we worked with to start with. And this lady who had metastatic liver cancer was very kindly the first patient we ever treated. She was the first patient ever treated by HIFU, extracorporeal HIFU in the Western world. She died some weeks later. And this is the team that we had. David Wild, sadly, no longer with us. He died, but the rest of the team are still alive and working on HIFU or other projects. And here we wrote up in the British Journal of Cancer the safety and feasibility of HIFU in a Western population. And as a result of that, got the European Community's approval for the HIFU machine back in June 2005. So I'm not sure if you can see the top of this, but this was some of the trials that we were doing. Extracorporeal from 2004 to 2006, ablation of large renal masses, then histology, then small renal masses, and then a second trial with small renal masses. We had a little bit of work looking at laparoscopic, and then some translational work looking at acoustic properties of perinephric fat. And these were the 17 patients on renal patients that completed, 15 completed, 2 were abandoned, and a 6-month follow-up. 1 had surgery. The ones that were abandoned, 1 had intervening bowel, which we couldn't remove. But 10 remained under surveillance, and some had further surgery. And here is an example of a small renal tumor with some uptake, which I think you can see there, a little bit of white. And here it is 12 days later, no uptake. And again, if you look at 6 months later, 1 year later, and even 5 years later, successful ablation of this small renal tumor with no recurrence and no uptake. Of course, laparoscopic HIFU is not non-invasive, it is invasive, but we did look at a patient with HIFU laparoscopically and then removed the tumor, and you can see that the laparoscopic treatment had a lot of ablative area there. But we stopped doing this because actually the purpose of HIFU, we feel, is that it is non-invasive, so there's not much point, we felt, in doing laparoscopic HIFU. I don't know if you can see this, ultrasonic properties of fat. There are 2 problems with treating the kidney. One is the ribs, which can get in the way, and the second is there's a lot of fat around the kidney, and this dark area here is fat around the kidney, and that takes away some of the HIFU treatment. So what we did was we took 10 patients who were undergoing renal cancer surgery, and we took perinephric fat from them, and we looked at this in a bath, in a saline bath, and put fat through transducers. And here you can see basically the thickness of the fat and the decrease in output of HIFU. So with 5 centimeters of fat, you only have a quarter of the intensity. And so we were finding with the kidneys that quite often it was the fat that was ablated and the kidney was not touched. Now, you may or may not know that with a renal transplant, you take the fat off and you put the transplant in the groin. So there's no ribs in the way and there's no fat. And here is a transplant with a tumor in. We treated it with HIFU and found that we got virtually total ablation. I did then take this out, and there was a slight small rim of tissue which was still viable, but 90% had been ablated. Of course, many of you are familiar, of course, with fibroids and the treatment of fibroids. And HIFU is excellent for fibroids. Here's a patient with uptake here. And here, 2 weeks after HIFU, no uptake here. 2 years, a little bit perhaps more around the periphery, but nothing inside. And of course, with HIFU, unlike radiology, you can retreat indeed as many times as you want. And the China 20-center study was a landmark study, which we helped to write up. We didn't have any participation in the treatment in this cases, but we helped to write this paper up. 2,400 women with symptomatic fibroids. And we looked, or you looked, the Chinese looked at complications, hospital stay, and the need for further treatment. 1,353 had HIFU, 472 hysterectomy, 586 myomectomy. Very, very few side effects with HIFU. The hospital stay, many of you who will be using HIFU know that you can do it as a day case under sedation. Many of the China patients came from a long way away, which is why they were staying for 4 days, but still less than hysterectomy or myomectomy. And as a result of this landmark study in China, it was written up in the British Journal of Obstetrics and Gynecology in 2017. And we had a much smaller study in Oxford with just 12 patients. We've treated more than that now, but looking at a 2-year follow-up period and fibroid volume reduction rate, which was again positive. And as a result, primarily of the Chinese study, but also of our study, NICE, the National Institute for Clinical Excellence in the UK, recognized ultrasound-guided HIFU for uterine fibroid treatment in 2019. I'm a urological surgeon. Prostate HIFU has been done for some years. I'm sorry about this unpleasant side, but it is transrectal, and an increasing number of studies show that the effects are as good as other localized treatment for prostate cancer. Prostate cancer is a slow-growing disease, and it's been shown that to treat it and to show a difference in mortality, you need to look out at about 15 years. But the side effects are less than in many studies. This is neurosurgical treatment for sacral chordoma. And this was a patient who had trouble sitting down. It's not malignant as such, but it's locally infiltrated and a very unpleasant tumor. And here is somebody who had pain, difficulty sitting down. We treated one side, we treated the other side. Here, both sides have now been treated, and the pain disappeared, and the patient was able to sit and have a much better quality of life. This was written up in the Journal of Neurosurgery in 2017. Targeted drug delivery. My colleague Konstantin Kousios and Paul Lyon were involved in this. Paul Lyon did this as his PhD thesis. And this is basically hypothermia by heating up a tumor in the liver to 42 degrees centigrade. So it's not ablation, but if you take a liposome, which basically has the consistency of butter, and you put doxorubicin, cytotoxic agents, into the middle, then at 37 degrees centigrade, this is stable, but at 42 degrees centigrade, like butter, this breaks open and releases the targeted drug delivery. So basically, you get a much higher dose in the area that you've heated up. And we were looking at primary and secondary endpoints, at the concentration, and also the effect on treatment. So basically, we were taking a biopsy of the tumor. We were then injecting peripherally into the vein thermodox, and then heating up this tumor. And then as the liposomes pass through, they break open. And we get here 2 to 9-fold increase in doxorubicin in 6 to 9 of the 9 patients in the area. And here you can see, here's secondaries in the liver on a PET scan. Here's an area that's been targeted, and there is no uptake there. And here again, the area that's been targeted, and you get this very high concentration of cytotoxic drugs in this point. And out of 9 patients with complete radiological assessment, they had most of them had good results with the treatment, and further two developed some recurrence in the tumor. But this was written up in the Lancet Oncology in 2018, and it was the first in-man study where this had been done, the safety and feasibility of ultrasound-triggered targeted drug delivery of doxorubicin in liver tumors. And we are now looking at pancreas, both as targeted drug delivery in the same way as liver, and also in ablation. And Professor Whye, who is with us, been with us for many years, but he looked at 8 patients with unresectable pancreatic cancer and found that pain relief happened in all 100%. And these patients eventually did die, but they had pain relief when even opioids were unable to control their pain. And here, if you can see it, there is some uptake in this pancreatic tumor and no uptake here. So we are looking at that now, as I say, both with ablation and targeted drug delivery in trials. I don't know if you know this saying, which is Theodore Roosevelt, the American president, which it's not the critic who counts, nor the man who points out how the strong man stumbles, or where the doer of deeds could have done better. The credit belongs to the man who is actually in the arena, who errs, who comes short again and again, because there is no effort without error and shortcoming, but who does actually strive to do the deeds, who knows great enthusiasms, the great devotions, who spends himself in a worthy cause, who at the best knows in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who know neither victory nor defeat. I think that's very appropriate for all those who are engaged in innovative research, especially HIFU. We know, I certainly know of the criticism of people who say it's not going to work, why are you spending your time doing it? But I think it's a person who is working, who is researching, who is trying to press forward the bounds of knowledge, that is the one who is in the arena, who is working hard. So we have had a fantastic time. We have ongoing time over many years to come, I hope, with HIFU, but we have a great team in Oxford, supported by various charities, of course, by Chongqing HIFU, the Institute of Cancer Research, so preclinical and clinical work. And I'm grateful to all these people and many others now who are not mentioned here, who have made Oxford a great success. Thank you very much indeed.